In this section of the course, I want us to look at the Compassionate Care Act that was first tabled in 2017 and was passed in 2020, and then this led to the overarching framework for the province. So in parallel, the Canadian federal government has also been working on this, creating frameworks for the whole country, and I'll be talking about that towards the end of the course, but I want to look at the Compassionate Care Act in this lecture. So it was tabled by this very young man. He's as young as he looks, and his name is Sam Oosterhoff, and he's the provincial MPP for Niagara West. And so he stated that his purpose was to develop a framework to ensure that every Ontarian has access to quality palliative care. And so we see then hospice and palliative care coming to its maturity at this stage, moving us into the present, and this is ongoing. So all of these different groups and activists and medical professionals and academics have all been pushing this. And so I'm just going to go through some of the details, but before I do that, I do want to talk a little bit about the person who tabled it. So one of the truly remarkable things about the Compassionate Care Act was that it was unanimous, and I think I've mentioned this before, that's almost unheard of in Canadian politics at any level. I mean, we are a democracy and people differ on many, many issues. So I think we have to take a moment and note how really kind of shocking this is and what this says. And so I think it says that palliative care has come into the mainstream and people recognize the need for it, and also that I hope anyway, that everyone can agree that we want to have what are referred to in the documents as compassionate communities. So I just do want to talk a little bit about Sam Oosterhoff himself, and so he writes, I looked on his Facebook page and there were comments after the act was passed. He writes, I pray it will serve to promote dignity and respectful palliative care for all at end of life. And so the language is not a euphemism. He's referring to prayer. And so he was one of the youngest MPPs. I think he was the youngest MPP ever elected in Ontario. He was 19 when he was elected or nominated. And so he comes from a very religious background, Dutch Reformed Church. And so according to the Maclean's article on him and his family, it states that he came from a pro-life family, homeschooled, socially conservative. And so I think this is important, and this is something I'm extremely interested in. How does religion play a part in society that is secular and multicultural? I think this is always a challenge, but also an opportunity in places like Ontario. And so I think he's a very good example. So may or may not agree with his politics overall, but this religious background is pushing him to bring this forward, this palliative care bill forward. However, it's couched in secular terminology, so that seems to be a good model for how this could roll out. So so according to the article, as I said, he was homeschooled. He was not allowed to watch television or Netflix, and he devoured books by people like J.R.R. Tolkien and C.S. Lewis, who you may or may not know are very influential Christian writers. And so it's interesting to see, and this is something I've definitely noticed in the palliative care world. You constantly come across religious people from a variety of different religions, not obviously all, but I do think, as I said, this is an interesting model for how the two could come together, and those resources and ideals from religion could be leveraged into the public sphere. So prior to the tabling of the private member bill, there were public consultations, and so again, You know, we get a lot of bad news about politics all the time, but I think this is a story that shows when it's working well. And so it was done very democratically. And according to the document, there were 40 stakeholders that were invited to the table to talk about what they thought were the gaps in the system. So the Ontario Medical Association, the Canadian Cancer Association, the Canadian Society for Palliative Care, that group that I talked about last lecture, and so on. And so all these different healthcare workers and people who had, as I said, were stakeholders in this issue. And so as a result of these public committee hearings, again, they're public, they're not done in secret. So it's very much done to try to access what people need in a variety of communities. And so the stated aim was to facilitate consistent access. And this is always the issue. And we saw with Cicely Saunders, she in the beginning anyway wanted hospice to be separate from the healthcare system, but it seems to me time has shown that it functions much better when it's integrated, and that's for a number of reasons. You can have standards of care, which is obviously very important. You don't want one community getting very low standards and another getting very high standards, and perhaps that being based on ability to fundraise. So this idea that we need to have standardized forms of care, and we also need to have consistency. And so a lot of this comes down to finances. And so with this act, it begins the process. Now we're still in this process of figuring out how this is going to work, but certainly the government, both at the federal and provincial level, are now giving steady streams of money to hospices. They don't just have to exist by fundraising, which is a very precarious way to go about it. So, so this young MPP was the person who moved this all forward, and I actually did send him a thank you note, and he replied with a card. And so I think I just wanted to give him credit for this, I think, a very selfless act. So what we find with the Compassionate Care Act is the beginning of the process of developing this larger framework. And so the Minister of Health is tasked with doing this. They're given a 3-year date to do it by and to have it ready. And so part of what this process does is get the lay of the land and look at what's already there and what's happening, and so that there's the ability to establish best practices. And so what they talk about how palliative care is accessed. So we can see how the system has developed so far, and we've talked about this throughout the course, that some of this happened pretty organically, partly as a result of the actions of the pioneers in the field, and also partly based on the needs expressed by communities. And so in terms of getting the lay of the land, the document states palliative care can be provided or accessed through your primary healthcare provider. Now, this is a very common way for people to access it and to get referred to a hospice. The problem with this, obviously, is that so many people now don't have a family doctor. And so for me, this becomes a huge issue. So services that can be coordinated in the home. So we're seeing that many people want to die at home, and so the development of these services that allow the person's family and the person to access community care. Long-term care homes. And so this is another place where palliative care is often needs to be improved and given more resources. So as it says here, many types of palliative care services are provided directly by primary healthcare providers who are already treating individuals for disease. For individuals requiring more specialized services, primary healthcare providers can provide appropriate referrals. So this is important that, you know, doctors have been doing this all along. So that's another way to access it. This doesn't get perhaps as much attention, but this certainly has been very common. So where palliative care is provided, all care settings, including the following: individual homes, residential and community-based hospices, long-term care homes, hospitals. So here we see how it is currently. These are all the places in which palliative care can be accessed. And so with the Compassionate Care Act, we see this effort to standardize this, to fund it properly, and to make it accessible to as many people as possible. So the Ontario provincial government was very quick to develop this. This is not something you often hear about government. They were very, I think because there was so much support for it. And so by 2021, we get the Ontario Provincial Framework for Palliative Care. And so just to note, 12 out of 13 of the provinces and territories in Canada now have these frameworks. So this has happened quite recently and very rapidly. And so this push to get an integrated system that's connected with the larger healthcare system. And so there's a short history in the document that I encourage you to look at. It's a good synopsis. So it notes that hospice and palliative care movement emerged in the 1970s. However, according to the document, the quality of care and availability was extremely variable. So, of course, this is one of the driving forces for standardizing this through a framework. By the 1990s and early 2000s, we see this drive to standardize through education of nurses and doctors and other healthcare workers. And then we have all these different coalitions pushing for this larger framework, including the Ontario Palliative Care Network established in 2016. Now, the document also gives some really useful statistics around age and chronic illness and death and dying in Ontario. And so it notes that 58,000 people live in retirement homes in Ontario. So again, this issue of the aging population, and this is set to just increase exponentially over the next 10 years or so. And so again, this is also part of what's driving the government to pay attention to this. And so according to the information as of 2019, 35% of those who die at home were able to access palliative care. So obviously they want to improve those numbers, or we want to improve those numbers. Also, 51% of deaths occurred in hospital as of 2019. And so that's actually gone down quite considerably, but still, that's a lot considering that most people say they would rather die at home. And the other thing, which is important to note, is that according to this document, it costs 40% more for people to die outside of these hospices or in-home care. And so for the government, there's many reasons to support this, and one of them is undoubtedly the financial aspect. If this saves money and it's better for people, that's pretty clear the way we want to move forward. So I just want to look at this definition. And so we've been talking a lot about definitions throughout the course, and it's interesting to see where the Ontario government's pulling from. So it says palliative care is an approach to care that aims to relieve suffering and improve the quality of living and dying for every person with a serious illness. It strives to help the individual and their family caregivers. Okay, so that's familiar. That's pretty standard. So to address physical, psychological, social, spiritual, and practical issues and their associated expectations, needs, hopes, and fears. And so this is very important, certainly for me, looking at this, that this doesn't get lost. This has always been one of the issues around standardizing, because again, we're in a secular democracy, and so there can be that typical where the action of just kind of pushing the religious, psychological, emotional parts to the side and focusing on, for instance, the bureaucracy of it. And so I was very pleased to see that this is front and center, physical, psychological, social, spiritual, and practical issues. And this is why I think that when we look back, we're going to see that hospice and palliative care was a kind of revolutionary movement in home care that brings it back to patient-centered care. So prepare for and manage end-of-life choices and the dying process, cope with loss and grief, treat all active issues and prevent new issues from occurring, and promote opportunities for meaningful and valuable experiences and personal and spiritual growth. I think Cicely Saunders would be thrilled with this. This is exactly, so this is her philosophy, and obviously from that longer history of hospice and palliative care. And so I think this is remarkable that this maintained itself through all of these many bureaucratic processes. And the idea of the human element of care and the human element in regard to the family and leveraging family and community support, these are all included within the framework. This definition is aligned with those of both the Canadian Hospice Palliative Care Association and the World Health Organization. It reflects the shift in practices away from focusing solely on end of life and towards a broader, more holistic approach that can begin as early as diagnosis of a serious illness. So there we see a change. Again, that idea of it not just being about somebody who's only has a few weeks to live, this idea that it can happen as soon as somebody is sort of in a palliative state. That could be a year ahead. And so we see that it's recognizing this shift, and it's trying to follow best practices connected with both the Canadian Association and the World Health Organization. So the document goes on to state, in Ontario, palliative and end-of-life care is provided in a variety of settings and by a range of professionals working together across the healthcare system. Physicians, nurses, social workers, and other healthcare providers offer care through clinics, hospitals, residential hospices, and home visits, including individual residences, long-term care homes, retirement homes, assisted living, and supportive housing. So we see again that idea of the team approach, and this is another model that's emerging, I would argue, out of hospice and palliative care, that idea of the lessening, we hope, of that rigid hierarchy within these professions, and that all are working together for the good of the patient, and in a variety of settings depending on what they need, what that person needs. And so this can include, as many of you will know, respite care. So that's another option where the person may be being cared for at home, but then spends a few days in a palliative care unit or at a hospice just to give the caregivers some relief. And so many studies have shown that we think about a third at least of people who are caring for people at end of life are showing symptoms of distress. So it's very important that they also get whatever supports they need in order to continue to care for that person. So it says, given that many individuals residing in long-term care homes have serious illnesses and most remain there until end of life, palliative care plays an essential role in enhancing overall care and quality of life for residents. And so we can see how, I'm not saying this is the only thing that's affecting long-term care homes, but there's been a lot of criticism of long-term care in Ontario and around the country. And so I do think these things are coming together to also have us look at how those are run. And so just one example, something I've read and something I've actually experienced is, I think I may have mentioned this idea of naturally occurring retirement communities where there's, say, a low-rise residential building that increasingly is attracting people who are older. And so the government is saying, why don't we just maintain those and then have a variety of healthcare professionals go in and check on these people and take care of them so they can stay in their home. So we're seeing, particularly as there's so many people moving towards retirement age and old age, that the government is having to really look at this very closely. And improve the care that's being offered. In the community, care providers often collaborate as interprofessional teams with varying levels of primary care involvement, supported by a range of palliative care specialists or experts, such as the regional palliative care networks. Additionally, family members, caregivers, and volunteers provide a sizable amount of care for all individuals with palliative needs. So again, the government's recognizing how much of the care is being done by the family, friends, and community, and sort of including that within this larger model and framework. So a huge piece of this is the funding. And so as palliative care and hospice care has come into the mainstream, we see that the government is willing to fund it. And this is a watershed moment for hospice and palliative care because if it's a strictly community-based endeavor based on fundraising, they're always in a precarious position. They're always under stress. Now, the government doesn't fund hospice and palliative care 100%, but there's now a kind of consistent stream of income, and that makes a huge difference. And it's true for the university sector as well. There's some controversy about this even within the sector of, do you want them to be funding 100%? Because if they're funding 100%, they're going to want a lot more control. So there's always this kind of give and take about what happens when it becomes standardized in this way. But certainly the way it stands, where it offers a portion, the government gives a portion of the funding, has made a huge difference in terms of the hospices not having to be in this constant state of trying to fundraise the whole amount for their operating costs. So I'm not going to say that some of this isn't, looking to get reelected. That's okay. But I do think that with this framework, we see that it's going to be ongoing and enduring, and also that all the parties signed on to it also indicate that, it's very unlikely anybody would try to revoke this. So from what we can see, it looks like this will be ongoing and maybe even expanding. And so, you can see all the different forms of capital expenditure and the rise from 67 million to 74 million. I'll let you read through this and read through the document. But the takeaway is that there are now opening up the coffers. And I think that, again, this is very practical because it's money saving for the government, and healthcare is a huge percentage of the provincial budget. So if they can get better quality care for less, of course, they're going to do that. And we can see investing over $5 million between 2016 and 2020 on educational and training. So again, that idea of recognizing that we need to be training people in these practices and approaches, and also throughout these documents it talks about raising public awareness, and that of course is ongoing. I did want to point out that the document, the Ontario government document, does mention assisted dying specifically. And I found it very interesting the way they handled it, because that became legal while this process was ongoing. And so it's very clear in this document that it says this doesn't impact the government's approach to palliative care at all. And so again, that was a huge issue, and I will be talking more about that a little later in the course. But how will that impact? Because certainly Cicely Saunders, unsurprisingly, coming from her religious background, was opposed to assisted dying. And so the philosophy of hospice and palliative care is very different. But the general public often doesn't understand that. And so it was very important that the government put that in the document. And I found it also interesting that it states in the document that very few people opt for assisted dying, actually. And so the concentration has to be on hospice and palliative care. And so they're making a clear demarcation between those two approaches. So, and I'm sure that came partly from the palliative care associations. Okay, so I wanted to end with some good news story here. This was posted on the CBC site October 18th, 2024, so just a few days ago, or a few weeks ago. And so the government is now contributing to the building of a new hospice touted as the first Indigenous-run on-territory hospice facility in Canada in the Six Nations of the Grand River. So this is completely run by the Six Nations. So according to the report, it's a 5-bed hospice that will incorporate Haudenosaunee teachings to provide physical, emotional, and spiritual support, and it will bring culturally appropriate end-of-life care closer to home. So I think this is, again, shows how the model works very flexibly. And so we can see that people are able to access within their community culturally specific care. So according to the article, the Ontario government is investing $1.25 million, and the Six Nations of the Grand River Elected Council is investing $5.5 million. So obviously the council is giving the majority of the money, but the Ontario government is supporting it. And so I will attach this article to the post, and you can read through it, but I thought it was, it talks about the process of how a family comes to be advocating for hospice care. And so it says, so it quotes one of the, so it says, according to the news release, once the hospice opens, the Ontario government will provide annual operational funding for nursing, personal support, and other end-of-life care services for patients. At one of the most sacred times of a person's life, we will have our own hospice to be able to support our members, their families, and loved ones as they complete their journey on earth, said Deborah Jonathan, Director of Wellbeing for Six Nations. It will be done respecting our ways and their wishes to ensure their next journey is a peaceful one.